Okay, so today we'll talk about sensory and communication with older adults, and we want to make sure that we cover some sensory deficits, and I want to also talk about my experience with cochlear implants so that you get a little bit of background in that as well. So, this lecture is covering quite a few different types of communication and sensory issues. And definitely, we should probably start at the basics just to make sure that we get those down pat and that we've reviewed those. So, remember that communication is really how we receive and provide information to and from others. We have a sender and a receiver. It's dynamic, so this ongoing exchange is back and forth, and it relies on intact senses, also physical and cognitive processes, and a conducive environment. Verbal communication relies on a common language as well as the ability to produce words, but it also relies on your ability to receive those words and comprehend what they mean. Nonverbal messages include tone of voice and physical behaviors like body language, gestures, eye contact, etc. So for older adults, a lot of older adults don't have any trouble at all. So when we talk about some of the communication obstacles that deal with older adults, we really are talking about those that are more isolated, that have lost their social networks through retirement, death of friends, family, neighbors, children moving away, those types of things. And then as the people spend time in their own environments, they might isolate themselves because of either where they live, health problems, or caregiving responsibilities. And then we can also have some physical or mental impairments that might impede or interfere with the ability to communicate. Whoops. Help if we went to the right one. Here we go. So remember that we're going to use all the therapeutic communication tools that you have covered before. Nursing 2100 covered quite a few of those. You cover some of those in mental health, and really we cover them all the way through the whole program. So anytime that you can reflect, show empathy, use those communication strategies to help you answer those crazy questions asked about that. But also realize that older adults need more time to respond because they're drawing information from much larger life experiences. So if you ask them a question like, so have you ever had an allergic reaction to penicillin? They may have to sit and think about, okay, first of all, when might I have taken penicillin? Um, and let's see, no, I didn't, no. And they're remembering and sifting through their life experiences so that they can give you an accurate answer. Um, it doesn't mean that they have cognitive decline. It means that they need to think through different life experiences to make sure they give you an answer that's correct. And they might come back to that question after a couple of other questions if they remember something too, to clarify that previous question. Also, listening carefully, clarifying, and patience are extremely important communication strategies. You use those with lots of different patients, but they're also important for older adults as well. All right, so you do need to know what intergenerational communication is. Make sure you know the definition of elder speak. Um, so obviously intergenerational communication deals with communication from one generation, younger typically, with an older generation. But elder speak is a negative communication pattern that you want to avoid. It's oversimplification, baby talk, you raise a pitch, repetitions, stressing certain phrases or consonants. Baby talk really is where we get to. So it's a negative communication pattern because it makes older adults feel like they don't know what's going on, or you think that they're stupid now that just because you're younger. So you want to make sure that you talk to them in a way that's appropriate for their abilities and their language, and not oversimplify communication. Um, and that's the best way to handle those types of experiences. When we talk about individuals with dementia, we'll talk about always making sure you introduce yourself. And that's okay. It's not the same thing as oversimplifying your communication. It's just another point of clarification if you know they already have a cognitive processing disorder. But you don't need to oversimplify if you have no previous background or experience with this individual. So there's some areas where we can think about have problems, or key areas that cause issues with communication and the ability to communicate. We can relate to dementia and cognitive impairment and how that can cause communication difficulties. Memory loss can be, and in the end stages especially, is associated with speech and language impairments and a decline in executive functioning. Alzheimer's disease is the most common form of dementia, and that's the most common type or form of cognitive decline that you will come across with older adults. There are many different types of cognitive issues, of course, and cognitive decline can be caused by quite a range of those. Not that we would treat each of those individuals differently, but we might need to use some different approaches based on the organic cause of their cognitive problem, or based on the abilities of the individual. So if you have someone who has suddenly they have cognitive decline, but they've suddenly lost the ability to use their hands really well, you're not going to ask them to write a message. Or if they can't hear and they have a cognitive deficit, you're not going to ask them to listen to something that they need to pay particular attention to. You're going to give them their message in a different way. And those are important characteristics that you need to pay attention to. And then speech and language. When cognition declines, the rate of speech will slow, but we might have some other reasons that could impact speech rate. Things like lost teeth or ill-fitting dentures, food impaction in the mouth where the individual is hoarding or keeping food in between their gums. If they have cognitive decline and they're not getting their dentures cleaned enough, they can get food impacted above their dentures that can cause problems. There's quite a few different things that could be problematic. Comprehension can decline with hearing loss or sensory loss, cognitive changes, and emotional factors. So you need to keep all of those in mind. And one good example, one of my faculty from my doctoral program mentioned when we were talking about sensory deficits, and she said she'd gone to visit her father in the hospital, and she walks into the room and there's a resident, probably a brand new resident, sitting beside the bed, and that resident is reading off a piece of paper and asking very diligent questions based on the assessment that they had been assigned to do on her father. And her dad's sitting in the bed, and he's got a grin on his face when he sees her come in, and she just stands there to listen. And the resident is asking questions, and her dad just starts saying stuff that's complete gibberish. So she walks over and she pulls out the hearing aids from the drawer and hands them to her dad, and he puts them in. And then the resident asks the next question, and he gets it completely right. And he was going to go on to the next question, and my professor said to the residents, said, you might want to start all over now that he can hear what you're saying. But the resident didn't even pick up on that was probably the reason why he was answering, and because the guy was giving the poor resident a hard time on top of it. But it's true that people with hearing loss may say things that are incorrect or not hear what you've said before, and they may answer anyway. And so the incidence of dementia diagnosis in individuals with hearing loss is 12 times more likely. But what we really don't know about that is whether or not they actually have dementia or whether they didn't understand the questions that were being asked. And then aphasia is the next pathological change and condition. Aphasia, there's many different forms of aphasia. Basically, it's the inability to get the word out, come up with the right word even though you know what it is. And individuals with strokes will have trouble with this and really get frustrated with this problem. So that's another condition that you need to think about and be aware of. There are 4 main neurological problems that impact communication. Reception, 3 main categories: reception, perception, and articulation. These really deal with neurological deficits, mostly related to stroke, but they can be impacted by some other things. So reception, we can have problems from a stroke that impact all 3 of these: reception, perception, or articulation. Reception is when I receive the message, right? So when I receive that message, I may or may not receive it correctly based on anxiety, disease process, fatigue, hearing deficits, altered level of consciousness, and any number of other problems. Certainly, a stroke is going to also impact the ability to receive messages as well. Perception is how I interpret those messages. How does my brain define, how does my brain deal with those messages so that I understand them? And those are affected primarily by stroke, but also dementia and delirium can have a big impact on perception as well. And articulation is my ability to speak and relay the message that I want to come out. And this is typically caused by problems of stroke, again, cerebral infarction, but also combined with some neuromuscular effects, usually when we see those types of deficits. So when we work with individuals with cognitive decline, such as dementia, first thing I want you to note is that dementia is a broad term. It is not a medical diagnosis, but a broad term that relates to cognitive decline, typically in older age. Dementia, we'll talk about dementia in itself as a full unit later on. But when you're communicating with persons who have a type of cognitive decline, you want to make sure that you call them by name. You focus on their feelings. So if they're frustrated, that's when you relay your basic communication and say, I can see that you're very frustrated. And you know those silly things that sound so ridiculous when you practiced them earlier in the program, they really work. So I can see you're frustrated. Very effective tool. Use your kind voice, but be real, be true. People can tell if you're not sincere when you're talking to them. And then tell them who you are. tell them your name. So you'll walk up to somebody like Ted at Tiger Place and you'll say, "Hi, Ted. My name's Carrie. Can I sit with you today and talk to you for a few minutes?" Now that's not overly slushy. I didn't need to focus on feelings for that example, but I called them by name and I used my name and introduced myself, even though that individual sees me every day or every week or quite frequently. Then you need to make sure that you know when to pick your battles. And with someone with a cognitive decline, that's almost never. You don't want to force an issue. Go away, come back in 3 minutes and ask them if they're ready for their shower, and they won't remember that you were there, most likely. So remember that you can take just a few minutes and let them calm down a bit and come back and start over with a fresh perspective yourself, and the individual have a fresh perspective too. It's important not to say, "Don't you remember?" or "You remember, right?" Because they don't remember and it doesn't matter. You don't want to argue with them. Just go with where they are and what's happening at the moment, and don't take any negative comments personally. It's a disease, not the person who's actually saying those things. A really common frustration for caregivers is communication, and it does require some special skills and patience. But what you can also do is to help really work with the significant others, the family members of the person with cognitive impairment. Work with them, teach them those same basic skills on the first part of this section. It's okay for them to be present and enjoy their parent or their loved one, even if that person doesn't know who they are. So teach them to take value in the time that they have left, to appreciate the time that they have left, and let things go, don't argue. And if they have to introduce themselves every time they come, that's okay. They don't need to say, "This is Carrie, I'm your daughter." Just go in and say, "This is Carrie, and can I sit with you and talk to you today?" Period. And that'll work out okay. They need significant support, the family members, to help with those communication barriers. We also want to make sure we include the older adult in communication regarding health matters. So invite them to the care plan meeting. Don't refer to them in the third person. Oftentimes what happens when you have some type of a care plan meeting, ask permission for the daughter or the whoever to come in. And if the older adult doesn't know, doesn't understand, or is getting frustrated, they will often go to that person, their caregiver, their family provider, and let them make those decisions. But let them decide that if they can. And if they're getting really anxious, you can say, "It looks like you're getting really anxious. Would you like me to take you back to your room now? Is it okay if we continue this conversation and I give you an update when we're done?" So just include them as much as possible. And then teach everyone to treat others with respect and to be a good role model. You need to be a good role model so that paraprofessionals or aides can be a good role model, so that family members and other people, dietary, everyone can be a good role model when dealing with these individuals. All right, that's part 1 of this lecture.